Okay, we'll get started, I think. Thank you all very much for coming on what is, as you all know, WESAC Day, and also Mental Health Awareness Week, and also it is the European Year of the Brain. So this remarkable coincidence of three important events is being celebrated by three speakers over the next hour or so. And I'm going to talk about depression, and then David Galanders is going to talk about acceptance and commitment therapy and mindfulness as a treatment for depression and other conditions. And then Stuart is going to come in and talk about mindfulness more specifically. And I think there might be an opportunity for some audience participation at that point as well, which will be something to look forward to. And then there'll be, after a pretty strict 1 hour, there will be leisurely 45 minutes or so for full and frank discussion and debate. And then we can all go our separate ways. So this event has in some way been sponsored or co-organized by people who work with the Global Health Academy and the university here, and in particular Lisa Wood, by representatives of the British Science Foundation, and in particular John Bradshaw, who I can't see anymore, and people from Edinburgh Neuroscience, and in particular Jane Haley. And I am sponsored this year by the Beltane Public Engagement Fellowship, so they should be acknowledged as well. My role is to try and engage people in rational discussions about mental health and ill health and its treatment. Myself and David are employees of the University of Edinburgh, and Stuart is an employee of the University of Glasgow. So, depression, a very commonly misunderstood word, term, and condition. In essence, what we talk about as psychiatrists and general practitioners and other health professionals when we use the word depression is not just being pissed off for a few moments one day because something bad may have happened or hasn't gone quite your way. It is a state of depressed mood most of the day, nearly every day, for at least 2 weeks. And that sounds bad enough, and it is. But it also, very typically, is accompanied by a series of other symptoms which are equally or even more incapacitating. Generally, people also have a problem with losing the ability to enjoy what were previously pleasurable activities, socializing, their hobbies and other outside interests. And in fact, to meet either of the diagnostic definitions of depression, here as represented in the International Classification of Disease 10th edition, produced by the World Health Organization, which applies everywhere in the world outside of North America. To meet that definition, you have to have one or other of those two symptoms. Most people actually with depression have both. And then you need to have a varying degree of additional symptoms on top of that. So energy loss or lacking with fatigue and feeling tired, restlessness or retardation, eating and weight disruption, usually a loss of appetite and a loss of weight, but can occasionally go the other way around. Sleep disturbance, again, usually insomnia, but can occasionally go the other way around. And then suicidal thoughts and negative or self-critical thoughts, perhaps including guilt, self-reproach, worthlessness, feeling lack of confidence or lack of self-esteem, and not being able to think or concentrate very clearly. And the observant amongst you will notice that this is just about a memorable acronym for depression, although that's about 10 years work in progress so far and still needs further work. But anyway, you can just about remember the symptoms of depression from the word depression with a bit of contrivance. And anyway, if you have number 1 and or 3 and 2 other symptoms, by ICD-10 criteria, you have mild depression, which is usually incapacitating, but would make people feel bad, but wouldn't necessarily stop them working or doing other activities in their day-to-day life. If you have 6 symptoms, and especially if you have so-called somatic syndrome, disturbance of sleep, appetite, energy levels, then you would have moderate depression, and work and other things will become quite difficult for you, and it will really depend on your job, how much you love it or hate it, and your attitude of co-workers and other people, whether or not you're open about your depression and how that's handled, as to whether or not you continue to work. Most people with moderate depression probably won't be able to work because their concentration or thoughts will not be sufficiently clear to let them do so efficiently. And they'll certainly be less efficient at work than they would be. And then if you've got 8 symptoms, you have severe depression. Now this seems a bit arbitrary, but actually that division in terms of the number of symptoms does have some predictive validity in terms of how long the condition tends to last. So on average, if you meet criteria for mild or moderate depression, your episode will last about 6 months. Some people much less, some people much more. But if the more symptoms you have, the more severe your illness, certainly if it's not treated, it's more likely to last up to a year or even longer. And so, to try and get the experience of depression across to you for those who have been fortunate enough not to suffer from it, I thought I would quote from what is my personal favourite account of depression in actually all of art, but particularly in literature, a book by William Styron, who's describing his own experience of depression. And the genesis of the depression he describes in this book goes through these mild, moderate, severe stages in his particular case and illustrates each stage. Sometimes people do go through from mild to moderate to severe. So he starts off, I'll read this to you, I'm sure you can all read, but I'll read it anyway. It was not really alarming at first, since the change was subtle, but I did notice that my surroundings took on a different tone at certain times. The shadows of nightfall seemed more somber, my mornings were less buoyant, walks in the woods became less zestful. That's the loss of enjoyment of previously pleasurable activities, which we sometimes call anhedonia, to give it a false ring of medical jargonism and superiority. I could no longer concentrate during these afternoon hours, and the act of writing itself, becoming more and more difficult and exhausting, stalled and then finally ceased. Ultimately, the body is affected and feels sapped, drained. I find myself eating only for subsistence. Food, like everything else within the scope of sensation, was utterly without savour. Most distressing of all, the instinctual disruptions, what we might call somatic syndrome in ICD-10 language, was that of sleep. Exhaustion combined with sleeplessness is a rare torture, as anyone who's had severe jet lag can attest to, but this is jet lag without an obvious cause very often and without end. And as things get worse, William Styron describes despair, which comes to resemble for him the diabolical discomfort of being imprisoned in a fiercely overheated room. And because no breeze stirs in this cauldron, because there is no escape from this smothering confinement, it is essentially and entirely natural that the victim begins to think ceaselessly of oblivion, with thoughts of self-harm sometimes, thoughts that people wish they were dead, and as things get more severe, ideas about how they might kill themselves. So this phenomenon is amazingly common. Another thing that's misunderstood about depression is just how common it is. People don't think it's as common as it is, I think, because people don't talk about it and feel embarrassed and ashamed about it if they are feeling depressed. But the best surveys, of which there are no fewer than 120 quite good epidemiological surveys from most countries around the world now, the best surveys suggest across the piece, more or less the average prevalence of depression is about 5%. 5% of humanity is depressed at any point in time. That's probably something in the region of 25 or so, or 30 of you, perhaps. But it varies across country to country, according to circumstances. This is an interesting pictorial representation of these prevalence is across the globe. And it's interesting because it actually challenges another few misunderstandings or misapprehensions about depression. I think a lot of us, perhaps with a romantic bent, think that less well-developed societies or cultures may have less depression. Well, as this map pretty clearly shows, the opposite is more likely to be true. The prevalence of depression is at its lowest, around about 4% in surveys that have been done in Australia, and parts of Southeast Asia. India and China have relatively low prevalence rates of depression. So does Western Europe and North America. As you can see here, highest rates, 6, 7, 8, 9%, and higher still are in many parts of Africa and Asia. And you'll recognize the appropriately red color for war-torn nations like Libya, Algeria, Sudan, Iran, Afghanistan, so on and so forth, where rates of anxiety and post-traumatic stress disorder are probably just as high as well. So it is a global problem. It is remarkably common. And it is disabling, as I've tried to get across to you. And indeed, the World Health Organization, in a series of global burden of disease studies over the past 10 years or so, have worked out from the prevalence of conditions and their duration and how disabling they are, that depression is probably the single most disabling condition affecting mankind because of its prevalence and duration. Measured in terms of this metric, disability adjusted life years, the number of years lived with disability, depression en masse is about as disabling as all cancer. And if you group all psychiatric disorders together, they account for something more than a quarter of all the years lived with disability around the world at any point in time and over the average lifetime. And that, as a group of conditions, is more common and more disabling than any other group of conditions. But do we get the same amount of research funding? No. Why is that? Well, I think it's the same, for the same reason that people don't talk about it. It's embarrassing or stigmatizing to have these conditions. And there's all sorts of, sometimes even well-meaning, terrible things that people can say to people with depression. Oh, well, you know, just pull your socks up, try a bit harder. And things will get better. If you are certainly moderately to severely depressed, it's very difficult to just pull your socks up and get a bit better. Even if you're mildly depressed, you can perhaps force yourself to do things against your inclinations, and that might get you back into the swing of things, and that may have some benefits. But you can't just snap your fingers and get better. If people could choose not to be depressed, they would. It's as simple as that. And indeed, they feel obliged not to talk about it, to hide it, and sometimes hide it from themselves. And a massive global survey published in The Lancet last year showed that about 80% of, I think, 3,000 people who had said they had suffered from depression said they had also experienced discrimination as a result of their depression. And indeed, 1 in 3 of them said that they had been actively avoided or shunned by people they knew because of their depression, which is a terrible state of affairs in itself. Even worse, it means that people don't tend to present to treatment. They don't get, sometimes they don't even get the benefit of sharing a problem and halving it with their friends and family, perhaps. They probably don't like to go to their GP and say they are depressed. They might prefer to go to their GP and say they have a pain in their back or whatever it might be. Now, this slide is a wee bit small, but hopefully I can take you through it and you can just about see it. The good news about depression, again, contrary to some of the misperceptions out there, is that there are a bunch of really effective treatments. So this is from a meta-analysis done by Maximilian Kuhn and colleagues based in Munich mainly, which is not yet out, but it's in the Journal of the American Medical Association Psychiatry wing in press. It's out as an EPUB. And the reason I picked this to show you is it's the most up-to-date meta-analysis of all the trials that have ever been done, actually here in depression, but across the whole of mental health, if you want to go and read about it. What this shows, in essence, is that from this systematic review of acute drug treatment for major depressive disorder, which is basically having mild to moderate depression. There are now hundreds of trials in more than 12,000 patients with depression, which show, on average, this kind of effect size in terms of people getting better within a few weeks from antidepressants. And this is called a funnel plot, although we sometimes use this technical term, which is a blobogram. And this blobogram shows the size of that effect, and the wee arrows sticking out the side of it are the confidence intervals, or the degree of confidence you can have in the size of that effect. So antidepressants work, and you can still read rubbish in the newspapers on almost a weekly basis saying that they are bad for you, they're addictive, they cause more harm than good. I just don't know where people, I don't know how people can say that, especially when they're doctors. It's absolutely appalling. Anyway, I'll get off my hobby horse in a minute. Then if you respond to an antidepressant and carry on taking it, the chances it will keep you well are even higher. And we know that, again, from loads of trials in about 9,000 and a bit patients. And then there are systematic reviews of randomized controlled trials showing that acute psychological treatments of various sorts, including cognitive therapy, including mindfulness treatment, have similar effects overall, maybe slightly better than acute drug treatment, but these confidence intervals overlap, so you can't actually say that really. But what they show is another effective treatment for acute depression. And again, if you carry on taking the psychotherapy or you carry on using the psychotherapy, you will generally stay well. And there's even good news for the Freudians amongst you in the audience, if there are any left, that psychodynamic psychotherapy works probably just about as well. So actually, there's a whole wide variety of treatments out there for depression. And people get hung up about which is better. Well, we don't really know that any is convincingly better than any others. The issue is what people would like and what's available for them, or what might be available around the world. Now, I'm going to self-promote here because that's part of my remit through the Beltane. I'm going to be discussing the issues about antidepressants and the mythology around them at this event on August the 8th at the stand in the square at St Andrew's Square as part of the cabaret of dangerous ideas. It is a dangerous idea that antidepressants are good for you. Scary but true. And that's just one event in about 30 that the Beltane Public Engagement are organising through the Fringe later this year. I've got a brain scan for you, because I know people like watching brain scans. And one of the interesting things about mindfulness in particular, to talk about the event we're talking about more tonight in particular, is the amount of interest in it that there has been from a very early stage from a scientific perspective, the number of imaging studies that have been conducted as part of trials of the treatment in clinical populations, but also in practitioners of mindfulness. It's an unusual treatment, if you like, which seems to have wider benefits in the population at large. And this is actually a large systematic review I pulled from the literature yesterday from a journal which has just published this account, which shows enlarged structures in the brain in these regions highlighted here in regular practitioners of meditation of various sorts. And again, I don't think people should get too hung up about this, because just necessarily having a bigger bit of brain isn't necessarily better. And even a flashing bright brain after a treatment isn't necessarily better, but it probably is. And what this evidence shows generally is that bits of the brain involved in processing body signals, body awareness, emotion, and white matter tracts that connect the bits of the brain, which are shown here in red, are all increased in volume in regular practitioners of meditation, and that includes mindfulness. So I'm going to close with 4 startlingly controversial and dangerous ideas. Depression affects 5% of the population at any one point in time. That amounts to 10% of all the years lived with disability around the world. But the good news is depression responds very well to a whole variety of treatments. And if you carry on taking the treatment, you are very likely to stay well. And what happens in clinical practice, whether you're seeing a psychologist or a psychiatrist and getting a drug or a psychotherapy, and perhaps both is probably best, is that once you're feeling better, you might slowly reduce the dose of the drug or slowly tail off the psychotherapy sessions. Neither of these things are addictive or dangerous. Okay, I'm going to finish there. So thank you for your attention. And